Hello, hi. All right then, so we're here today for a teacher training session. So we're here with Sophia, who is a physician associate, and she's kindly going to present a couple of case-based discussions. One is on, the first one's going to be on loss of consciousness query cause, and then the second one we're going to talk about ankle swelling case study as well. And yeah, that's about it really. So Sophia, if you can just tell me the story, present the story for this patient, and then we can talk about it in some detail. Okay, so over to you.
So I had a 23-year-old female that I
Right.
spoke to over the phone. Her only prior medical history that I could find was just some ferrous fumarate tablets.
Right.
So when I was speaking to her, she said that for the past 2 weeks she's been having some episodes of where she's been losing consciousness.
Okay.
In the past 2 weeks she's had 3 episodes of syncope and 1 episode of dizziness. She couldn't find any raceable triggers or anything that kind of is contributing to these episodes. They've all happened quite sporadically at different times.
Right.
One of the episodes that she thought about in particular was when she came out of the bath. She had just come out taking a bath and she was putting her towel on, and then she noticed that she started to feel dizzy, she had some tinnitus, and then she fell back into the bath.
Okay.
She doesn't know how long she lost consciousness for. A lot of these episodes have happened without anyone around for a character witness.
Okay.
So she isn't able to comment on whether she's had a seizure with that. And with that episode I queried whether she had any head trauma with it, and she said that she doesn't recall it, and with all these episodes she's never gone to seek any help in A&E or anything like that. So the past 2 weeks she's had 3 episodes. One of the episodes was seen by her boyfriend. They were walking down their local high street, and all of a sudden she had the tinnitus and the dizziness.
Right.
And she ended up losing consciousness while they were walking. She said that with that episode it only lasted a couple of minutes. Her boyfriend didn't know any tongue biting, incontinence or any head injuries or anything like that, and no seizures.
So no shaking at all?
No.
There was no obvious shaking when she was out for?
Yeah. And then once she woke up, she said that she felt like a generalised body weakness, almost like she couldn't move, like a slight paralysis almost, which lasted a few minutes with some laboured breathing, and then after that she returned back to normal. They carried on with their journey. I've tried to query why she hasn't kind of seen us, why she didn't seek any help at the time, just only because it's not a normal thing to happen, and she just said that she just at the time, because she didn't hit her head, she didn't see the point in kind of seeking more help. She has had 2 episodes of syncope in the past, one when she was 18 and one at 21. Again, with all these episodes she's denied any incontinence and tongue biting, but she can't comment on whether there was a seizure, and she can't think of any triggers. The only recent issue that she's had with her health was anemia, which she's on, an iron deficiency anemia, which she's been started on ferrous sulfate for, but she isn't compliant with her medication. She doesn't take it that often. She does also suffer with migraines, but she doesn't feel like it's linked to her migraines either.
Okay, keep going. Past medical history?
Past medical history, apart from that there's not really anything else relevant that I could find on the system. She's, apart from the ferrous sulfate tablet, she's not on anything else regularly.
That's all, is it?
Yeah.
Okay. And was it a phone call, or did you examine?
No, it was a phone call.
So examine. Okay. So what issues are remaining here? How would you then manage this?
So this was a patient I actually really struggled with, and I was really stuck on. I didn't really know where I could go from here, because she kind of doesn't fit something. She doesn't fit like a regular kind of slot that I can kind of put her into.
Okay.
And it was one that I booked with a doctor for further follow-ups, just because, to be honest, I don't really know where I can go from here. It's a case that I struggled with quite a lot. One of the main things I struggled with was determining, was it urgent enough for me to send her to A&E, but she currently wasn't having any symptoms and she felt well in herself. Or was it something that we could wait until she's kind of had a proper assessment in person?
Right.
I did consider bringing her in for a face-to-face with myself, but I kind of just had to put into perspective that at this current moment, I don't really feel confident managing her case in the first place, and I don't think I would have been doing her any justice bringing her in to see me as well.
Okay.
Yeah.
So basically you decided to book an appointment with a doctor to deal with it, yeah?
Yeah.
Okay. So, all right then. So, okay. So it's basically loss of consciousness, query cause.
Yeah.
So you need to just try and think of what the common causes are, what the slightly less common causes. So, have you ever? Just try and think. Have you ever been told a mnemonic to remember the causes of any sort of condition or disease?
Only just Socrates.
Socrates.
Yeah,
okay.
just for pain and.
Okay. Yeah. Okay. So I'd like to teach you a decent one called Invited ICI Manager. It's a mnemonic. So I is for infections. So N is for neoplasia or cancers. V is for vascular causes. I is for autoimmune causes. T is for trauma. E is for endocrine causes. D is for drugs. I is for iatrogenic, which doctors have caused it. C is for congenital causes. I is for idiopathic causes. And M is for metabolic causes. So invited ICI manager. Okay, so it's a good thing to think about if you're really struggling about what you can think of any cause of disease or and it can go with loss of consciousness. But so using that as a framework, let's start with I. Infections. Do you think infections can cause loss of consciousness?
Yeah, absolutely. Yeah, especially if it kind of reaches level like sepsis and things like that.
Yeah, absolutely. So
high fevers.
yeah, so infections can do it. And neoplasms.
I
think any neoplasms can make you collapse and fall. Yeah.
Absolutely,
So brain cancer is one of them. V vascular. What vascular things can make people just lose consciousness? Do you think?
Hypertension.
Hypotension.
Yeah.
Very good.
Vasovagal syncope.
Yeah. So vasovagal syncope is the number one potential diagnosis with this lady. She's 23 and she's kind of giving with getting out of the bath, you can get. It's quite common to get a quite a massive vasodilatation and a drop of blood pressure in your head. Vasodilatation while you're in the bath, sorry, but when you get up, your brain kind of drains a bit of blood. If that makes sense. Because the blood is more on the outside rather than the inside, if that makes sense. So that vasovagal, yes. Any other vascular things that you can think of that can make you drop?
Vascular issues. I'm trying to think. Postural hypertension, but that kind of.
That's kind of said that.
Yeah.
So basically, it's anything that can cause a sudden insult of lack of blood to the brain. Yeah.
Yeah.
So in practice, that can be a heart attack. It could be a bleed in the brain, a stroke or something.
Yeah.
And aortic stenosis is one of them. So that's a narrowing of the outflow pipe from the heart that can do it. Mini stroke, TIA can do it as well. So that's the sort of things I'm thinking there.
Okay, fine.
So by doing that mnemonic, we've already covered quite a lot of potential causes there. But we'll keep going with the thing just to see if we can think of others. So where are we now? Vascular. I is Autoimmune, yeah. So autoimmune, I suppose you could say diabetes is an autoimmune condition. So where it can attack the pancreatic cells, but the vague indirect link I'm getting here is low blood sugar attacks.
Yeah.
All right, so low blood sugar just can make you just collapse or lose consciousness.
Yeah.
So I'll be thinking about someone who's got diabetes, but she doesn't seem to have diabetes.
Yeah.
But it would be a good idea to check for diabetes.
Yeah, absolutely.
And also, while we're on the topic of blood tests, we might as well also check for anemia, because that can make you weak and drop as well. So especially with that history of iron deficiency anemia. So where are we now? Autoimmune T, trauma. Yep. So trauma, banging your head can make you lose consciousness, but she kind of lost consciousness before she banged her head in the bath, and then walking in the streets as well. So drugs, can drugs make you black out? Yes, they certainly can if you overdose on them, but I doubt there was anything like that there. And then you've got doctor making someone black out. Yeah, absolutely. We can give drugs that can drop their blood pressure. And congenital, don't think so. And then idiopathic, there's always that. You don't know. And then M is metabolic. I think we covered that. The only other one which is important that I haven't mentioned that doesn't link with my mnemonic is epilepsy. Yeah, so that's something to think of. Okay, so that's the sort of thing. So you think of the causes, and then you kind of think, well, how am I going to manage this? Yeah. So you need to you've taken your history. You need to examine. Yeah. So with examining, you need what would you examine to kind of cover those sort of causes?
I would start off by taking her blood pressure.
Very good. Just one blood pressure, just blood pressure sitting?
No, lying, sitting and standing.
Lovely. So what's a significant postural drop, do you think?
Over 20?
Yep, 20 or more on the systolic. Lovely. And if it goes below 100, but it's more about the systolic drop. Yes. Anything else?
I'd possibly do a full cranial nerve exam. Just to test. The nerves.
Ideally, you do a cranial exam, but in general practice, you just have to do a quick sort of scan. That's just the way it is, unfortunately. But you would pick up any obvious facial nerve weakness or any problem with the eyes of nystagmus. That's the main things you just need to check for. Papilledema, ideally, for a brain tumour. Okay, great. So you've examined what else would you examine on the body?
I would do a cardio exam. So I would listen to
very
the
good.
heart.
So you're listening on the cardiac. What are you specifically listening to and hearing?
Any murmurs?
Yeah. So you're going to try and listen for aortic stenosis. And anything else you think of that's relevant?
Any signs of anemia in the face? Maybe?
Yeah, very good. And heart rate's important to see if it's going too fast or too slow or irregular. Because remember, cardiac arrhythmias is one of the main causes here. Okay, great. So that's the main things to examine, basically. And then you would do blood tests and special investigations. So we've mentioned blood tests already: full blood count, HbA1c, probably do a U&E, glucose, but that's about it. What other tests would you do in an ideal world to look at the main causes of loss of consciousness?
Would it be relevant to add like a thyroid function test, or?
So would thyroid give you a loss of consciousness? Not really, no.
No? Okay, fine.
So you should have a framework on investigations, So you think blood, urine, X-rays, special investigation scans. Yeah, so you just need to think like that.
Ideally, a CT of the head.
Yeah, so CT head, so we can do that, but in GP land, we've got MRI head scan, but which would be pretty well good enough. So MRI head would be an option. For her, it depends on the examination. I think I would do an MRI head scan, yes, alter that. Any other special investigations you can think?
ECG?
Yeah, so ECG and a 24-hour ECG heart monitor check for a heart rhythm disturbance, and echocardiogram would be useful as well. So you can do those tests to start off with, and then you can consider a neurological referral if you're not getting much from the tests, or if it's not obviously vasovagal, and then they will do an epilepsy test.
Yeah, okay, fine.
So, but my gut feeling is it's more likely to be a vasovagal faint. Okay, fine. So that's that. So the difficulty for you was basically not knowing what to do with investigations. Yeah, you haven't had much experience in this one yet.
No. I don't really get syncope so often.
Yeah, but it's always a face-to-face examination. It's one of those things you can't do over the phone. So there we go. So how did you think you did with this case?
I don't think I've done that well.
I mean, how did you? What I'm trying to say is, how do you think you did well? Let's start with that.
Fine, okay. I think what I done well is I kind of remembered to explore symptoms like the prodromal symptoms, postictal kind of stuff, trying to identify a trend within everything going on.
Right.
I think that's kind of where I think I done well in this case, and asking about prior episodes and things like that, just because it wasn't mentioned. What I thought I could have done better, I think my issue with this case was I got flustered, and because I couldn't find like an obvious cause kind of speaking to her on the phone, and because to me when it comes to like syncope, I was worried about pathology of the brain or anything like that. I thought, am I working safely in letting her kind of come back to see a doctor rather than
you were concerned about whether this could be an A&E call. So I mean, for me it's not an A&E call because they've kind of it's not an acute crisis. So if they for instance if they drop down in front of you where they lost consciousness, then that would be more that would be more of an A&E visit. But they recovered, so you've got the benefit of them getting better. So okay, so I like the way how you gave a good story about the fainting. It was good and complete, and I think that was good. So is there anything else that you think you could have done better?
Exploring the rest of her symptoms. Kind of once you've broken down the mnemonic I could use, it almost seems like I could have just explored her symptoms a bit better as a whole and her as a person to find the cause.
Try and just remember. I mean, it's good. Just try and remember that mnemonic, and then it just makes it a little bit more easy. Okay. The iron deficiency anemia. I think probably. I was just thinking whether perhaps you could have asked a few more questions on that to work out why they are. So basically, is it due to them being vegetarian? Is it heavy periods? I mean, for a 23-year-old, it's usually one of those two. But if it's GI bleeding, it would be a bit more obvious. They would actually say that they're vomiting or strange poo or black vomiting. But you do need to just zone in an ideal world, zone into that and just get some clues about that. Okay, lovely. Okay, well that's that case done. Great. Let's move on. So the second case is about ankle swelling. Um, so if you could just tell me the story, and we'll go from there.
Sure. So I initially spoke to this 34-year-old female on the phone. She has a past medical history of mitral regurgitation as a baby, and she also has a history of hiatus hernia and gastritis.
Yes.
But she booked in a telephone consultation because she had been getting this bilateral ankle swelling. It's around the foot and ankle area. It doesn't radiate any higher. She said that she's been getting this on and off for a few years, but the day prior to her appointment, the ankle swelling had started, and normally once she elevates her legs, it would clear, but this time that didn't happen,
Okay.
which made her quite concerned because she had spent the whole night and it was still there. She had some associated stiffness in the ankles as well because of the swelling, and from that she also said that she had slight shortness of breath in kind of extreme climates, so hot climates and cold climates, and then also when taking the stairs, but apart from that, nothing else. I then brought her in to examine her today. And then,
wait. Anything more on the past medical history?
just the hiatus hernia, mitral regurgitation, gastritis, and then some backache.
Asthma as well?
Oh yeah, sorry, asthma
Yeah.
too. Sorry.
Yeah.
So she's on regular medication for her asthma.
Okay.
She's on 2 asthma pumps, and she's also gets a regular prescription for Laxative as well.
Okay.
Yeah.
Okay. Yeah, great. Okay, keep going. So you're now going to talk about what? So did you examine, or did you bring in, or
Yeah,
you
so
examined? Did you?
yeah.
Great.
I
Okay.
brought
So
her in-
tell me your examination findings.
So when I brought her in the next day, so there was bilateral ankle swelling. The left leg is worse than the right. So the left leg, it's I would say maybe slightly bigger than the right, but it's also the swelling is kind of diffused over the dorsal aspects of the foot and
Okay.
radiates up to the ankle. With the right foot, it's kind of in the toes and slightly in the dorsal aspects of her foot,
Right. Okay.
but not around the ankles. There was no calf tenderness. It was a non-pitting edema.
So non-pitting. So you pressed on it and it didn't leave a dent, basically.
No, yeah.
Okay. So when that happens, what does that make you think?
Fluid.
So that makes me think fat, really.
Fat. Oh,
So
okay.
so with fluid, when you press on it, it
Yeah.
usually leaves a dent.
Mm,
Yeah.
okay.
But if it's kind of puffy and you press on it and it
Yeah.
doesn't leave a dent,
Yeah.
it's more likely to be fat. So, and then the other thing you need to think about is arthritis of the ankles as well. Was there any pain at all in there?
She had slight pain of her left ankle,
Okay.
not of the right, and her left ankle was the more swollen one as well.
Okay, so you examine the legs. Okay,
Yeah.
what about her general appearance? Because this is really important to finding the cause.
She seemed really well in herself.
Okay, what about her size?
Yeah, she had quite a large body habitus.
So would you say she was obese?
Yeah, her
Okay.
BMI is around 27, I think.
I think it's around 29 about
Oh,
6 months ago, isn't
Okay,
it?
fair enough.
So, okay, so, all right, so she's overweight, she hasn't got any pitting edema, and she's got she's got slight pain in the right ankle, and shorter breath. Okay, keep going.
Yep. So then I listened to her heart as well. Her heart sounds were very faint.
Okay.
But both were heard. There was no signs of a murmur. Her blood pressure was actually on the lower side. It was around. I don't have it on me, but it was around.
107/78.
Yeah.
Yeah.
Pulse-
Yes.
Pulse
Okay.
was regular, around 80 beats per minute.
Okay.
And I also listened to her lungs because I was worried about any fluid, if she was fluid overloaded. And the chest was clear, no signs of crackles or a wheeze
Okay.
that I could hear. Apart from that, I don't think I done. Yeah, that's mainly what I done on examination. Her gait was unaffected, so no signs of limping or anything like that. Yeah, I've ordered some blood tests for her.
Okay, so what blood tests would you order for her?
So I think I ordered a full blood count, and a ferritin. I think I also ordered a thyroid function test,
Yeah.
and I think because of her size, I think I also ordered a HbA1c test as well.
Yeah,
Just kind of
diabetes check, very good.
Just to do as routinely. More specifically, just to kind of rule out anything more sinister with her heart, just because I was worried because she has a history of mitral regurgitation. I also ordered an echo,
Yeah, very good.
just to kind of get see how her heart's doing and if it's kind of emptying properly. But now knowing the pitting edema stuff, I probably might not have done that, to be fair.
Okay. All right then, great. Okay, so what issues were raised for you in this case, do you think?
Again, it was another one where I was kind of more worried about something a bit more sinister, and worried about...
More sinister?
Yeah.
What do you mean by that?
Just anything, just like heart failure or anything like that.
Okay, heart failure, yeah.
Or any like renal problems.
Okay.
That's kind of like where my mind was travelling to. I was just a bit worried about if I was missing out like a medical emergency in terms of any cardiac issues. What else was I thinking? I was also thinking, although I'm doing some investigations, how can I help her in the meantime? Because I wasn't sure what I could do for her while she's waiting for these to kind of go ahead.
Right. Okay. All right. Okay. All right then. So I think you were thinking of possibly frusemide as a possibility.
Yeah.
Okay. So that kind of depends on what you kind of think the cause of the ankle swelling is. So if it was, for instance, obesity related fluid retention, then frusemide can be an option.
Yeah.
Or if you think it could have been heart, then frusemide would be a good starter. But I think with the examination, I would probably kind of go down the way of weight loss and blood tests, really.
Okay.
And I would sort of just think if there was any arthritis there as well. As you mentioned, some sort of ankle pain, didn't you?
Yeah.
Moving. Okay. That's that. So, how do you think you did well in this case?
I don't think I'd done this one quite well at all, to be honest. It was one that I really struggled with again. Yeah. Because I think what happens is with some things, especially if it's not an area I'm 100% comfortable with, I almost get shell shocked.
Okay.
And I'm thinking, am I not acting fast enough for something more sinister to happen that I'm kind of missing out?
I mean, it's about just experience, and it's about knowing what the red flags are for any sort of symptom, and just sort of thinking, well, could it be that? If not, then you should really kind of just sort of relax more and just think, well, I can do some tests and just see where we go with this one. But it comes with experience, really. But yeah, no, I like the way you did you requested the blood test. You thought about diabetes and the thyroid. I like the way you didn't ignore the mitral regurgitation from birth. I did look at the notes from the cardiologist back in 2016 about it, and it said that there was a thickened prolapse of the mitral valve, and they wanted, it says here, I would like to see again in 5 years' time. That was for a repeat, I think probably for a repeat echocardiogram.
Oh, I see.
It was a normal left ventricular function, but a soft systolic murmur in 2006. And then what happened was a GP in 2014 did another echocardiogram, requested it, but it was never done, and then it's all gone quiet. So,
I see. Okay.
So I think doing an echocardiogram, even if it isn't fluid retention, which doesn't sound like it, would be a good plan anyway, just in case that's causing her shortness of breath rather than her being overweight.
Yeah.
So that was good, the echocardiogram. And also the asthma thing is, I looked in the asthma, how it was diagnosed. It was actually diagnosed in 2015 by a nurse, and it seemed to be correctly diagnosed. There was reversibility testing done on spirometry with a salbutamol, and there definitely was more the objective test of reversibility more than 14% on the FEV1s after giving salbutamol, and spirometry was apparent there. Do you know much about spirometry and diagnosing asthma? You kind of remembered that once upon a time, or just generally do you know how to diagnose asthma objectively on tests?
Wouldn't it be that you just do spirometry without treatment and then give an inhaler and then try again?
Yeah.
To see
So
the
well,
lung function.
yeah. So what you do is, in an ideal world, you can either do three things, and this is what the NICE guidelines in 2000 and recently 2020 21 recommending. So basically, you can do a spirometry with reversibility. So you do your spirometry, you get your FEV1 and you get your FEV1 stroke FVC percentage. And what you're doing is you're getting that value, and then you're repeating it after salbutamol has been applied, a few puffs of salbutamol. Then you repeat the FEV1 and you repeat the FEV1 stroke FVC percentage. And what you're looking for is an FEV1 percentage of more than 14% increase, or you're looking for a 200 milliliter increase of the FEV1. All right, and then you can say, well, there's some reversibility, but you can't just diagnose on the objective test. You have to have the history of typical asthma. So that means short of breath, coughing, worse in the morning, wheezing, often variation worse than last thing at night, first thing in the morning.